in 2009. Our Global Genes team is really excited to be able to bring this program to the Lambert-Eaton myasthenic syndrome community. Well for taking the time out on a Saturday morning or Saturday afternoon, depending where you are, to be able to join us for our first virtual meetup. We're going to be recording this meetup posted on the Living with LEMS website within a week, as we have quite a few patients who wish to be able to attend today that weren't able to join us at this time period. So I want to thank you for joining us this morning, and I would like to introduce you to our featured guest speaker, Dr. Francie Hsu from UCLA. Dr. Hsu?
Thank you, James. Thank you, Carrie, for the kind introduction. Thank you, Amanda, for the kind invitation, and thank you, Ashley, for the webinar coordination. And mostly, ladies and gentlemen, good morning and good afternoon. As I know you all are sitting at different corners in the world, and it's an honor and delight. I would like to say hi. It's really an honor to be a part of the neuromuscular community and meet all you here. So thank you for being proactive by attending this meeting. Today is Lambert-Eaton myasthenic syndrome. Identifying potential conflict of interest. The questions we'll address today are: what is LEMS, and what treatments are available, and what's beyond the frontier? Lambert and Eaton, among the first physicians in Mayo Clinic, substantially described the clinical and electrophysiological findings of this disease in 1956. And myasthenic in Greek means muscle weakness. So altogether, you have a syndrome called Lambert-Eaton myasthenic syndrome with a set of medical signs and symptoms. LEMS patients weak. Scene takes place at the neuromuscular junction, where the nerve or the yellow tube turning into a yellow ball meets the muscle or red meat-looking thing. The tubular structure is the nerve. The bottom wave-like structure is the muscle. So command for the body to move. This drives a rapid change in the charge inside the nerve at the terminal of what's called depolarization. Inside of the nerve becomes more positive than usual. The calcium goes into the cell. I see through this red voltage-gated channel. And so through this channel, when the calcium goes in, you have all these acetylcholines get ready. So these acetylcholine can then get released. They're the little red dots inside the round vesicles, the neurotransmitters. Once they're released, they bind to the muscles, causing depolarization and contraction. So let's zoom in. Electrical signal that arrives, calcium channel to open, goes in to the nerve, and then the choline or neurotransmitter goes out. In LEMS, the LEMS antibody attacks the calcium channel. We have an antibody attacking the red, the round channel, and calcium cannot go in, and acetylcholine cannot come out. So muscle contraction becomes difficult. That's why LEMS patients are weak. So what LEMS antibodies? 50 to 70% of patients with LEMS have an identifiable cancer. An overwhelming majority are small cell lung cancer. A tumor related to LEMS. Lung cancer cells originate from the neuroectoderm, which is the most exterior layer the early embryo. They share antigens with peripheral nervous system tissue, including those mimicking voltage-gated calcium channels, or VGCC. And antibodies to VGCC theoretically suppress tumor growth, but also attack the neuromuscular junction. What does this mean in English? Tumor cells are derived from a layer of cells that also give rise to the peripheral nervous system, or nerve. The tumor cells carry some markers that nerves also carry, as voltage-gated calcium channels. Therefore, your body tries to fight off the tumor by producing antibodies that target against the tumor. But simultaneously, the antibody mistake innocuous, harmless calcium channels as enemies too, and destroy them. So this is called perineoplastic LEMS, namely an indirect effect of the neoplasm. So what are those that don't have tumors, you may ask? That will be our next topic. But for those with tumors, in addition to small cell lung cancers, you can have non-small cell lung cancers, neuroendocrine carcinomas, lymphocarcinoma, malignant thymoma, cancer of the breast, stomach, colon, prostate, bladder, kidney, gallbladder, and rectum, basal cell carcinoma, leukemia, lymphoproliferative disorders such as Castleman syndrome or Hodgkin lymphoma. And so it's crucial to undergo serial surveillance, imaging, and evaluation to identify and treat the tumor as soon as possible. The majority of the patients do not have a tumor and called non-perineoplastic LEMS or autoimmune LEMS without tumor. So you usually see those in patients that are young women, and they're commonly associated autoimmune disorders such as rheumatoid arthritis, lupus, inflammatory bowel disease, primary biliary cirrhosis, myasthenia gravis, etc. So this is concordant with LEMS being an autoimmune disease. Also, patients ask, why do I have autonomic symptoms like dry eyes, dry mouth, blurred vision, constipation, decreased sweating, or erectile dysfunction? Because there are also antibodies that direct against the N-type calcium channels that are located on the autonomic nerves. Symptoms include exacerbated by hot weather, hot baths, ache and stiffness during or following physical exertion, droopy eyelids, double vision, difficulty speaking or eating, and numbness. So the diagnostic workup covers clinical history, examination, blood tests, nurse study, and imaging, at least. And now we have some understanding of the basis of the symptoms. We can move on to understand the rationale of the different treatments. So there's a patient with tumor, and 90% of those have lung cancer. First, the first step is stop smoking of the culprit or the tumor through various means: chemotherapy, radiation therapy, laser therapy, or endoscopic stent placement. And actually, through a good number of references, alcohol-following tumor treatment is truly very well. Patients recover quite well from the muscle symptoms and demonstrate improvements in their electrophysiologic studies. So now we move on to the second step of the treatment. If the tumor gets removed, and also for those group of patients that do not have tumor. So it's a very important thing to manage the symptoms, to relieve the symptoms such as weakness and easy fatigability. Remember, LEMS calcium channels do not open long enough to keep the cells positively charged inside the nerve. And so a cascade of things can happen. And so the muscle can receive appropriate signals to contract. See that. The channel called potassium channel. When the red triangle binds to the potassium channel, potassium ions, which are positively charged, could not leave the cell. And this makes the cell stay positive inside, which prolongs depolarization of the nerve action potential. And hopefully that can allow the calcium channels to stay open and allow the acetylcholine or the red dots to get to the junction of the nerve and the muscle, and then later allows the muscle to contract. I want you to know, what's this red triangle? Actually, it's called 3,4-diaminopyridine phosphate, or 3,4-DAP. So that's this ring structure. It's structurally related to benzene, with a difference of a nitrogen placed here. So this ring is attached by these two amino groups, third and fourth positions. That's why you have 3,4-diaminopyridine and phosphate. So basically, the phosphate salt of this count is helps to provide stability in this formulation, so that it would not require refrigeration. Actually, amifampridine is a non-proprietary active ingredient for the red triangle, or the 3,4-DAP. It is first used in LEMS in 1983. And it's documented efficacy and safety in more than 70 patients, with doses ranging from 24 to 80 milligrams per day. So in 2009, it is approved in the European Union, including Norway and Iceland, Israel and Switzerland, under the commercial name Firdapse. In 2011 Cochrane review described the results of 4 randomized controlled trials in a total of 54 patients with LEMS. All reported a significant improvement in the muscle strength score, metric limb measurement, or SAP, after treatment. So that's a measurement of the nerve function, the nerve test, or the CMAP. So with the previous promising results, again, amifampridine was studied. And it's a clinical trial known to date for Firdapse. Evaluate the efficacy and safety of amifampridine phosphate, a phase 3 randomized double-blind placebo-controlled discontinuation trial was performed at multiple academic centers with a total of 38 patients. And ever occurred to you, what does really phase 3 mean? Physicians use all these medical jargons, and so actually, a phase drug is deemed to have some therapeutic effects, with the prime goal for this phase of the clinical trial to assess the efficacy or the effectiveness and the safety of the drug. It's most difficult, it's expensive, and it's time-consuming. And specifically, the effectiveness relates to how well a treatment works in the practice of medicine, and the efficacy measures how well treatment works in clinical trials or laboratory studies. So you see, this is Firdapse, and it's multinational in the United States and Europe. And United States, it's multiple states from Alabama, Arizona, California, Kansas, New York, to Europe, including France, Germany, Hungary, Poland, Russian Federation, Serbia, and Spain. three phases in the study design. The first part is the open-label phase, during which patients were treated with amifampridine for at least 91 days. Two is a double-blind treatment. And so these patients continue from the part one open-label phase, were randomly assigned to to two groups. The first one being to be continued on amifampridine, or the second group to be tapered down to placebo over 1 week, and then continue placebo during the second week. Now I'll move on to the third part, which is an open label phase for 2 years. So one of the primary points for this trial is to show the change in muscle strength during the part 2 phase, or the discontinuation period, on day 14. And compare those that were still on the drug versus those that were already moved to placebo. And so the study used a test that's called quantitative myasthenia gravis, or QMG. It's a physician-rated evaluation, consists of 13 assessments, including tests for arm strength, leg strength, and neck muscle performance, swallowing, grip strength, forced respiration, and gaze impairment. Lower scores reflect better muscle strength. And one of the secondary endpoints is to measure the change in walking speed. Or in other words, how long do the patients take to travel for 25 feet? And specifically, FIRDAPSE achieved statistical significance in the primary endpoint. In other words, strength was better in those taking the drug and not the placebo at day 14. And this improvement was statistically significant. As you can see, the placebo has a score of 2.2, and the FIRDAPSE, the medication group, has a score of 0.4. Remember, I said the scores are better when it's lower. Now, moving on to the secondary point for the measurement of the speed of the patients when they walk. We did find that it's worse in the placebo group at day 8. In the titration period, when the placebo group is being tapered off of the medication and transitioning to placebo. So statistically significant worsening speed in this walk test was up to day 8 in the placebo group compared with the drug group. But anyway, there was no statistically significant difference between the two groups at day 14. To move along, in August 2013, Catalyst Pharmaceutical Partners received breakthrough therapy designation from FDA for FIRDAPSE for the treatment of LEMS. And current is that Pharma this year in June announced its agreement with FDA, confirmatory phase 3 study protocol for FIRDAPSE in LEMS. Catalyst expects to initiate a small single-center study for FIRDAPSE during the second half of 2016. So another study, again, to finish up maybe some of the questions there are for the previous study. So in addition, EAP, or Expanded Access Program, was initiated. It's an open-label study in order to help LEMS patients. Catalyst Pharmaceuticals is providing FIRDAPSE for free. So you want to know about the safety of this medication. For the clinical trial, there's no serious adverse event attributable to this medication that was reported in the phase 3 study. no subjects chose to stop the treatment due to adverse events in the blinded portion of the study. So effects were benign and waned over time with continued use of FIRDAPSE as patient tolerance improved. So what were some of the side effects? So few were reported, and they were mild, transient, and dose-related. As my research coordinators can testify. So we see patients with paresthesia, that means numbness and tingling in the extremities or around the mouth. Very occasionally, heart palpitations. And so these patients should be monitored regularly by EKG to see if there's any abnormal rhythm in the heart for the initiation of the treatment. And this medication is known to increase the risk for seizure, especially with high doses of 100 milligram or more in patients with history of brain metastases. In one of the studies, a total of 10 patients, that's 0.69%, of the patients out of 1,454 patients were healthy subjects experienced seizures or convulsions after treatment with amifampridine. Other symptomatic treatments. We talked about 3,4-DAP. So there's some symptomatic treatments that were out previously tried, and the first is called acetylcholine esterase inhibitor, or pyridostigmine, or a treatment that's more commonly known called mestinon. So the mechanism is to increase the acetylcholine in neuromuscular junction. Remember, it's the red dots inside those round circles or the vesicles at the ends of the nerve terminals, and they're the neurotransmitters. And actually, in the nerve test, you can see improvement in the response of the nerve test. But medication is also not without side effects, including cramps, or spasm of the windpipe, or increased salivation. In my control trials, it's seen that there's improvement in mestinon plus 3,4-DAP. So combination regimen may be helpful. Now, move to the next symptomatic medication or medication for symptomatic treatment. So it's called guanidine, and it's also a potassium channel blocker. So kind of like the 3,4-DAP, and it augments acetylcholine release. But the unfortunate thing is that it has much more severe side effects, affect the bone marrow, the kidney, the liver, and also the gastrointestinal tract. And that's why its use is limited. So now ask, what if I have severe weakness and have not responded to symptomatic treatment? This is what we consider immunotherapy. So it includes corticosteroids, aspirin, cyclosporin, rituximab. These are the main ones on the list. And it could have serious side effects if taken chronically. Prednisone is simple. It can inhibit the white cells migrating to the site of inflammation. It can interfere with inflammatory mediators. It can stop the antibody from acting. And it reduces swelling and formation of scars. So it's very versatile. It does a lot of things, but overall job is to suppress inflammation, to kind of cool down the hyperactive immune system. It's not without its major side effects, such as gastric ulcer, and this is by stimulating the secretion of gastric juice. It has high blood pressure by retaining the sodium in your body. It may cause diabetes by opposing insulin and stimulating hepatic formation of the glucose or the sugar. it can break down the bone. So for other medications such as azathioprine and cycloprine, it can cause skin cancer, lymphoma, or serious infection. And rituximab can cause severe skin and mouth reactions or serious brain infections. So to the next step. In patients with exacerbations of weakness that requires immediate short-term intervention, one would recommend plasmapheresis. So what's that? It's basically removal of blood through a catheter. It separates blood, the plasma from blood cells, and so then it discards the plasma which contains the antibodies. And so the patient would then receive placement, donor plasma, and usually you see peak response in weeks after the treatment. The effect wears off by the end of 3 to 4 weeks. And patients need the addition of an immunosuppressant to sustain the response. Potential complications include autonomic instability, elevated calcium in the blood, and bleeding. So the other choice is IVIG. So it's also indicated during periods of acute deterioration and given 2 grams over kilograms over 2 to 5 days, and improvement in 7 to 10 days, with the effect lasting for 4 to 8 weeks. Side effects are headache, chills, and fever. Less side effects during slow infusion rate and hydration, and some serious adverse effects including kidney toxicity, stroke, and irritation of the lining around your brain and spinal cord. So this is a scheme for treatment for LEMS developed by the EU or the European Union, or according to this is obtained from the European Journal of Neurology. And basically, once LEMS is confirmed, one of the very first things that physicians try is 3,4-DAP and move on to screen for cancer. If small cell lung cancer or any other type of cancer is suspected, then of course the immediate approach is to treat or remove the tumor. There's no tumor screened, then just like those that were treated, that had undergone tumor removal, we'll treat the symptoms based on the level of the weakness. So mild weakness, we continue 3,4-DAP, and then stenone could be added. So the one that could allow the state or augment that would augment the acetylcholine or the neurotransmitter at the neuromuscular junction to promote muscle contraction at the end of the signaling cascade. And patient has severe weakness, but with just mild chronic impairment, then we would recommend prednisone or another immunosuppressant. If the patient has severe and acute impairment, like I was describing, IVIG plus prednisone and azathioprine or plasmapheresis plus prednisone and azathioprine is considered. If they actually do really well, medication can actually be weaned off. There's some other important management. Therapy, occupational therapy, braces recommended by special orthotists, pharmacotherapy for autonomic symptoms, and simple things like avoiding hot weather, hot baths, and avoiding strenuous exercise. And of course, It's so important to have fun. Remember to have fun. I cannot stress enough that our opportunities are present when you closely online resources, patient stories, education meetings, importantly, faith. Faith is believing even when we don't see or hear. And I'm a big believer of miracles. Miracles at different levels, from daily personal matters to future global changes. If you have weak muscles, your heart and mind need to be strong. When you're this way, you're the real winner in life. And actually, you have so much to offer the rest of the world. Everyone has a different story, and everyone needs encouragement from you, too. And I also would like to commend all the dads, moms, brothers, sisters, husbands, wives, kids, and the rest of the family that's taking care of your loved ones with LEMS. Kudos to you, your fighters, with big, strong hearts. Last, thank you very much, everyone, for your time, and I hope I will have the honor of seeing your beautiful faces one day. Can move to Q&A?
Yeah. If anybody has any questions, please feel free to send it in the box below. And I want to say thank you to Dr. Hsu for this presentation, as well as a special thank you to Catalyst Pharmaceuticals for providing our Global Genes team unrestricted educational grant for us to be able to provide not only this program, but the Living with LEMS website and all the other activities that we're working to provide for the LEMS community. As I mentioned earlier, this webinar has been recorded, and we will have it up in the Living with LEMS website, livingwithlems.org website, within about a week. You are also welcome to reach out to us through that website if you have any questions or comments, or if you would like to share your patient's story. One thing we would really love to do on the livingwithlems.org website is build our patient stories. So if you would like to share your stories and help encourage others who may be newly diagnosed with Lambert-Eaton myasthenic syndrome, or who have been diagnosed for a while but are just trying to dip their toe into being more proactive in terms of being an advocate for themselves in the community, I'd love for you to share your story. Thank you again for joining us today. Thank you, Dr. Hsu. Thank you, Catalyst Pharmaceuticals, for this opportunity. And I hope everybody enjoys their Saturday afternoon. Thank you.